Welcome to the Reverse Mullet Healthcare Podcast from BP2 Health. Today we're in the studio talking with Andrew Molosky, President and CEO of Chapters Health System and CareNu, about seeing patients as stories, not diagnostic codes. But first, who are we? Why are we here? Why did we name our podcast the Reverse Mullet Healthcare Podcast?
Well, we want to be relevant, informative, and creative, but we also want to be entertaining and have fun. So it's like a party in the front and business in the back, like a mullet first.
We're your hosts, Ellen Brown,
Dave Pavlik,
And Justin Politti.
We are passionate, innovative, and collaborative, and are committed to solving some of our industry's most important issues together with our clients. We have a combined 90 years experience.
A bunch of old folks, that's what we are.
Yes, with Andrew, it's probably at least...
It's got to be 120, I would say, right?
There you go.
All right.
In each episode, we're going to dig into a hot healthcare topic and dig into each other a little bit.
but just please don't dig into me. Be gentle on me, please.
Yeah, we never really gentle on her because
No.
she's like our little sister, and we will dig, and keep digging.
Well, I'll just dig right back.
Noogies. That's what I always say.
Yes, exactly.
Well, let's introduce our guest today. Andrew Molosky is the President and Chief Executive Officer of Chapters Health System, one of the nation's premier community-based healthcare delivery systems. Chapters Health is a progressive leader in delivering innovative, risk-bearing programming, hospice, palliative care, home health, durable medical equipment, and pharmacy services designed to improve the lives of those affected by advancing age and illness, serving a wide geographic area, including the Southeast and Mid-Atlantic regions of the United States. He is also CEO of CareNu.
Yeah, because that wasn't enough. That other thing isn't enough.
There's
right?
more. There's more. He's the CEO of CareNu, a value-based subsidiary of Chapters Health System, providing predictive analytics, case management, and one of our favorite things, social determinants to care delivery. Andrew served in executive leadership for more than 20 years, spanning an array of geographies.
30
20
years.
You got it, 20 years exactly, including publicly traded organizations, privately held, and not-for-profit. He led Unity Point at Home, held leadership positions at Seasons Hospice and Palliative Care, Emeritus Home Health and Hospice, and Heartland Home Healthcare and Hospice.
Okay, but before we jump in, even to the party in the front, we're going to make it even more party in the front. So before we recorded, Andrew might have donned the mullet. He might not have. No one will ever know. It's like a tree falling in the forest. And as he put it on, you guys said...
Justin said he looked like...
Nikki Sixx. I mean, it was a spitting
And there
image.
was a story, and I said,
But wait, who's Nikki Sixx? Some people might not know who Nikki Sixx is.
If we have to describe who Nikki Sixx is, I don't want the listeners...
Oh, no, you can't say that. Explain who Nikki Sixx is. We don't want to...
I want to alienate listeners.
Well, let me do that because who Nikki Sixx is fundamental to the story itself.
Okay,
right?
all right,
So,
perfect.
Okay.
told in a very succinct fashion, right? There are people of a certain age and recognition. Nikki Sixx is a household name.
Yes.
My wife is not one of them. So as I'm traveling through an airport a number of years ago, it was very clearly obvious that Nikki Sixx was about to board the plane with me because he is very clearly Nikki Sixx. It's tattooed on the knuckles, the hair is distinguishable, the dress is distinguishable, and he had autograph seekers all around him, right? So I had the privilege of sitting next to Nikki Sixx on a plane flight right after his book had come out. And he was an exceptionally nice person, by the way. For those of you who are always looking for testaments as to who is this person, he was very kind, very conversational, and wasn't bothered at all by my fandom. Right. So in this process, I had just read the book, of course, and said to him, you got to tell me what I don't know, especially about the day you died twice.
Okay.
And his exact comment was, that was a terrible day. Poignant, prescient, right? I mean, talk about a
Now,
quotable
he can
moment.
deliver a line, huh?
Yeah, with emphasis. And so I text my wife and I said, I'm sitting next to Nikki Sixx. And she said, she sounds 80s hot. And I said, well,
She's thinking Tawny
first,
Katane,
it's
something.
a he, and you're right. So that is when someone drops a Nikki Sixx reference, I thought, oh, there's a special someone in my life who I just have to make it clear is the last to know who Nikki Sixx is. But thank you for the reinforcement.
But
I might
after
have
all of
broke
that,
down
hold on though. After all of that, that was outstanding. We still didn't say who he is.
Mötley Crüe,
Thank you, drummer.
Kickstart Tommy Lee. No, the Tommy Lee is the drummer.
Oh, that's right.
Oh my
bad.
gosh.
Bass player.
Justin's going to disown you
I know,
too.
man, this is really disturbing. What is going on that side of the table?
I made a mistake. He's the bass player.
But come on.
See, nobody knows who
Vince
bass
Neil?
players are. Singer.
All right, there we go.
See,
All right, I
this gets
feel like
even
we need
crazier.
to
I'll be
stop
making a
now.
run for
All
that
right.
chair.
Right. I feel like the
Man,
whole
I didn't-
BP2 partnership could fall apart right now. Like we need to move on from that. So thank you for that fantastic story.
Okay, so after that was actually awesome. Appreciated that.
I try to bring
As if
value
the
where
other
I
stuff
can.
isn't going to be awesome. That-
Well, everything else is
Party in the front to a
right.
new level.
Right. Wow.
Maybe you could bring Nikki Sixx next time. That
I'll
would
work
really
on it.
take it to a new level.
Well, yeah, that'd be my takeaway.
Let's get into your love of water sports and the saltwater aquarium where you raise corals and reefs. Can we hear a little bit about that?
Yeah, certainly. I mean, people all have passions and hobbies. You know, a lot of folks are into gardening, a lot of folks are into cooking, and you know, along the way, I picked up this hobby, if you will, that started off as many, you know, in that space do. You get your first little aquarium for Christmas, and you killed off a couple of goldfish, and usually people give up at that point. But you know, mine kind of hung around for a little bit longer, and so in that process, you know, as I grew up and lived in environments where I had access to those sorts of things, it became a real passion, right? It moved past a hobby and now into something that I actually have the opportunity to give back a little bit into the world. And so, yes, as you indicated, we at our home have a very large fish tank, but one of the bigger parts of that is where we're able to coral garden, and we're able to raise captive coral fragments to take back out and reseed the reefs in collaboration with very well-respected institutions. I'm not just out there freelancing on my own, but you know, it is a nice thing when your hobby can actually be giving back to nature as opposed to purely just taking from it. So, yeah. There you
How
go.
many gallons is said tank?
Said tank is a little over 1,000 gallons, right? So it's
I actually had saltwater tanks growing up as well. No, as an adult, I should say. Killed the goldfish growing up, but
Right.
loved saltwater fish. And I don't know, I guess I eventually killed them off too. But mine was 70 gallons.
Yep. And you know, it's like many things, right? It's the principles remain the same, and it's just how you apply them. And ironically enough, you know, there comes an analogy that I draw to a lot of our healthcare pursuits from time to time, and that's, you know, nothing good happens fast, right? You know, if the tendency to react and do things quickly or on a whim or on a spur usually backfires more often than it succeeds, right? And so, you know, an aquarium hobby, as you firsthand know, is it takes time, it takes love. You can't fix things fast. You can't make them happen fast.
Yeah.
And you just have to be planned and methodical and patient and stick to your guns, and good things happen over time. And so that's been a pretty practical lesson to apply to the healthcare environment, which will eventually come around,
Yeah.
I'm sure.
Yep, you will. And,
We're getting
you-
close.
And you know what?
Right.
I think the last guest we had this conversation, and now with you here, I now know more than ever that Ellen, we pick guests because they do Ironmans and stuff like that. And so here we are again with yet another guest that has these shared interests with Ellen, related to, you know, little things like Ironman and Ironmans. Is it an Ironman or
Surfing,
Ironmans? How do you say what's plural for
I'm a
Ironman?
sporty girl. That's the bottom line. I'm a sporty girl.
No arguments from this.
Yeah,
Try to be
tell us.
well-rounded, right? You know,
Yes.
Pets and
Yes.
musicians and outdoor activities. And,
I play one on TV, but let me assure you, I am rocking the top knot most of the time of my life in sporty clothes.
I
So,
like that.
Yes.
Well, tell us about it.
So what is it? First of all, we had to define who Nikki Sixx is.
That's right.
What is an actual
That's right.
Ironman?
In the spirit of
Nikki
I think
Sixx
I know what an
complete
Ironman is.
An Ironman.
there's got to be
That's a
some
lot to
questions
unpack.
I'm not allowed to weigh in on, right? Like, well,
I think I know what an Ironman is. Can I try to guess?
Yes.
Okay. It's running, swimming, and biking.
Yes.
Okay. I don't know the distances though.
Okay.
excellent. That's so much better because oftentimes if you hear Robert Downey Jr.'s name come in, that's the wrong Ironman. We're not talking about that. So, yeah, the distances, the Ironman refers to a specific set of distances. Of course, triathlon is the sport itself. And then when you say to someone, I ran an Ironman or I'm training for an Ironman, it's a specific brand and it's indicative of certain distances.
Oh, okay.
And those distances in an Ironman are 2.4 mile swim, 112 mile bike, and then a full marathon, which is 26.2 miles of running or walking or crawling, as it may be more often than not the case. So, yeah, to say you do Ironman is indicative of that's your level of commitment. And again, like the aquarium hobby, like the healthcare pursuit, it's fast if you're really doing it well. It's very slow in my case, but it's methodical and it's a great day out.
That's not true. That's not true. I just want to be clear that, okay, so I had, as Dave and Justin know, because we have all worked together for 20 years.
Hard to
off
tell.
and on. Yeah. And they truly are my brothers. And so I had my Ironman phase, right? We all have our phases, but I was a half Ironman phase. I just want to be clear.
Yeah.
But I will tell you, the half is always my distance. I love a half marathon, which is 13.1 miles. I like half distance. So the half Ironman was like perfect for me. Super competitive. Ended up going to world championships, got my podium there. It was amazing. And Kona, So I am jealous though, because Kona is on my list, but what I've decided is I don't make good life choices when I'm training for races. So now what I do is I train with friends who are doing races so that I can say no, right? They're still on the ball, but then I say no. But I am saving for the Ironman until I'm in my 60s, because then not as many fast girls show up and I have a better chance at qualifying for Worlds. So when you said, in my case, you're not telling the truth, because you also shared with us that you qualified to go to the World Championships for Ironman. And I know race times, and I know your age group, and you're not walking it. Let me be clear. So tell us about your most recent experiences.
Yeah, ironically, I think it was this weekend. It may have very well been, it was September 10th of
Did you
last
do Utah?
year. No, I did Nice, France.
Okay.
And it was this weekend last year. It was a great privilege to go and,
Worlds. I'm sorry.
Worlds,
I thought you were
yeah.
talking about your qualifying race.
Oh, my apologies. No, the last full distance Ironman that I actually did was Worlds, literally almost a year ago today.
So you've just, right, exactly.
And then have been doing a number of things over the course of the summer and the spring. I don't want to say I took the year off. That's not even accurate. But as full distance Ironman goes, that was a pretty fun day for me. And so we're in a little spell. We'll do a half here in Florida in December. So that's the next one on the books. And and then to your point about Kona, I have the privilege of saying I'm already locked for October of 2026.
Nice. So you requalified and you get to go to Kona.
We will be in Kona, and realizing that dream. So one of these days, very soon.
Yes. Anyways, all right.
Well,
I'm geeking out on this.
I learned what I learned here is that a triathlon can be, as long as it's the 3 events, swimming, running, and bicycling, it can be different distances.
Exactly.
So now what I'm wondering is if Justin and I could do a triathlon.
You could do a sprint. Do a sprint triathlon.
Or when I get back,
absolutely.
When I get back to my friends, maybe that's an event.
Have you ever seen what these people look like swimming, like crashing into each other?
I'm talking about swimming 50 yards, biking about half a mile.
Well, I think sprint is a very manageable distance.
Absolutely.
Well, it's something we'll have a future podcast episode about our Dave and I training for it.
Okay.
Love it.
Let's do it.
All right. No more triathlon talk for now.
Okay.
For now.
Partying the front's over.
Yeah, it is.
Wah, wah.
Yeah.
Wah, wah.
So let's talk about what you think could affect real change. And that real is in caps, because that's what we ask all our guests in this important issue. And so I'm really interested to hear what your thoughts are.
Yeah, and it was kind of queued up in the introduction, and I really like that was the case, right? I think most simplistically put, I think real change can happen independent of your space within healthcare, right? Because we speak of healthcare writ large, but what people fail to capture is there's so many parts to healthcare. There's so many segments of healthcare, focuses, niches, et cetera. To affect change, though, I think is a universal answer. And I think when the system, again, the royal we, sees patients as a story, right? Doesn't see them as their chart, as their sum of their medical diagnosis, as a billing code or part of a sequence of events. When you look at someone and you see a 56-year-old engineer who's just trying to get to their daughter's graduation, if you see someone as a mother of 3 who wants to make certain her kids have the most time with them possible, your approach to delivering care changes. Your empathy changes. Your look at what is the best care for them changes. And that follows all the way down the pathway. Your views on reimbursement change, your views on follow-up and accountability change. And it sounds so simple to do, but it's the old butterfly effect, right? Or dropping a stone into the water and watching the ripples take. That initial approach has such long-lasting ramifications to the entire system that's just kind of the soapbox that I like to get on, because you say, what one simple thing can really hold impact and change? That's where I always start.
I will say this. I wanted to be a physician when I was growing up, and I couldn't cut it in college chemistry. And so then I got into the business side of healthcare eventually. And I always said, I feel like I can impact people's lives if I can help bring outcomes-based payment transformation, healthcare delivery into mainstream medicine. Because if physicians are incented to help people with their outcomes, right, which is this idea of the person as a person with their story, how to handle that, as opposed to how many times they can come see me so I can get more money, right? So I'm totally with you that it is. I've always believed that paradigm shift is absolutely paramount to shifting and really affecting change. So
Yeah, well, I think it's needed in our system today, the way we're so fragmented. And it's very easy just to look at somebody and treat like just where you are within the spectrum, as opposed to like looking the person holistically and really understanding what it is. Like they're a person, person first. So
That's why you're a perfect guest for this podcast, because we've literally spent decades on payment transformation, right? Shifting from fee-for-service to value-based care and outcome. So tell us the good, bad, and the ugly in terms of shifting
Yeah,
from
you bet.
fee-for-service to value-based.
Well, I'm glad I bring more than knowledge of 80s hair metal.
yes,
right?
you do.
So
And that's why we
don't-
always have the party in the front.
the
and
layers
business
of
in
the
back.
onion, right?
don't discount the effectiveness of that. That was very effective.
You find your in where you can, right?
Justin's like, let's just wrap it now.
Yeah,
This is a
we're
done.
fantastic
Right.
podcast.
Yeah, the goods, bads, and uglies of transformational healthcare delivery, right? I'll actually probably avoid the ugly. I don't know that ugly is necessarily a component of this to me, but I think goods and bads are a fair starting point. And I think there's an old adage, and I'm not going to give credit properly, but there's a saying, and apologies to whoever coined it. Every system is perfectly designed to get what it gets, right? And it sounds simple when it's said out loud, but when you really stop to think about it, it's not the system's fault. It's how a system is applied. And if you don't like the results you're getting, you work on how that system is built.
Absolutely.
Right. And to that end, we at the organizations that I had the privilege of representing with both chapters and CareNu had said, okay, our problem is not the people. Our problem is not the patients. It's not the payer mechanisms. The problem is the system. And if we don't like that, then we should take the bull by the horns and try to address the systemic issues.
Yep.
And in doing so, we focused first on the good. What is the best part of what you do? It's your mission, it's your orientation, it's your calling. And in our specific line of work, which really focuses on care for the chronic ill, the elderly, the frail, right, as opposed to, more the maintaining the wellness of the youthful populations, things of that nature, we have a very specific population that we look to work with. And in that process, we realized we needed a very specific type of employee base, right? And so you can start to see where this goes. Now you have a different group being served than has historically been served. You have a different workforce being cultivated and nurtured than has traditionally been cultivated and nurtured. And you start to build a system in its own right. And eventually, and listeners are going to be asking, that sounds great, how do you get paid, right? If you bring a value proposition to the table that says, statistically we're different, culturally we are different, as care outcomes go, we're different. We're targeting a population that's different. You have created a system, or you have at least embraced a system differently than exists today. And that creates audiences, that creates buy-in, and it creates sort of that cultural competency and currency of an organization to say, now we have enough traction to do this differently than others, right? The bad is, if you don't have the good fortune of an organization to be nimble, to be quick to change, to be have stakeholders who are lined up behind you on this journey, you've got some headwinds, right? It's not a secret. I'm going to, again, screw up the numbers, but the concept is accurate. The United States economy is one of the largest in the world. Our healthcare spend as a portion of our own economy is one of the largest parts.
4 trillion.
4 trillion. I thought it was
4 trillion.
4.6.
It's
Yeah.
like 4.5. Yep.
Mhm.
Yeah.
I didn't want to take a chance on record of getting it wrong, but I feel that much better.
But the per capita expenditure is twice as much as the next
Yeah,
closest
and our
one.
outcomes are the worst.
Bingo. You finished my statement.
Sorry.
Oh,
No,
sorry.
absolutely
Wait, we're
right.
finishing sentences now.
This is going
I know,
swimmingly.
right?
Yeah.
This is fantastic.
Very prescient crew.
And to that end, that means there's a lot of system already in place. There are a lot of stakeholders. There are a lot of investors. There are a lot of protocols. If you as an organization are going to build from the ground up, you have the good fortune of saying, yes, we don't have a lot of traction today, but we get to start this the way we want it to be. If you're a very large institution with years of muscle memory, so to speak, you're going to have a different path to that. But to your point about good and bad, it's still a system. And like any system, it starts with moving one brick at a time, one Lego at a time, one block at a time, however that looks. And you just have to determine your path.
You said it really well, and I want to go back to this point. It is, and you didn't say it exactly like this, but it was the idea that economically you have to align with the outcome. So, hey, look at the savings that I'm generating. Look at the economic value that I bring in the model of care that I have created. in the system of care delivery that I have created. And you're willing to stand up and say, and I'm confident in that, and I'll stand behind that commitment. And guess what? If I save that money, it's mine to keep. But if I lose it, it's also mine to lose. Unfortunately, that's where we have created a system that doesn't require that. And so to your point, if you're reporting to a board that's used to seeing margins on a bed, on a stay, on an admission, on a DRG basis, right? It's very difficult to think about the financial risk associated with a $12,000 a year premium versus an $1,800 daily bed rate. Do you know what I'm saying? So
Absolutely.
I think that's a really important aspect of value-based care that people can't seem to get over. And then we all point fingers at each other, right? But there is an absolute that when you create the value, they will come.
That's right. Well, and I tend to draw oftentimes bad metaphors or bad analogies, and I speak in them, and my team has just gotten used to it so they can decipher what I'm trying to say. So I'll be very kind to the audience and not go down that path, but I will attempt one shabby one. Last night as I was kind of just thinking through tomorrow, as we often do, I was like, all right, what are going to be my speaking points? How's this going to come out articulately? And I kid you not, in the time that I was just sitting there with TV running in the background, 2 or 3 law firms came on, and the same adage was there: you don't pay anything unless we win, right? And then there was a pizza at local pizzeria. It's if you're not completely satisfied, you get your money back. And I thought to myself, accountability and value-based exists in almost every other line of work. Why is healthcare the last, and it so often is, the last to adopt what the rest of the world knows about? If you have a product and you're confident in your delivery, and if you are accountable to the results and you're an expert in your space, the notion shouldn't scare you. The problem exists is people have gotten comfortable and people have these well-oiled machines and expectations. So oftentimes I would tell people, you probably have more competence than you realize. What you have lacked is a purposeful, strategic plan on how you change other stakeholders' views on this. I doubt very sincerely you've had any guest on this podcast who doesn't believe they're providing top quality care to their patient or their member or whomever their population is. But you probably had more than a couple who said, but I wouldn't be able to convince other people to go a different direction. So that's what I usually focus my conversation on.
Well, I think part of it is, it's also just a fundamental, I just want to be clear too, is taking insurance risk is very different than offering healthcare delivery.
Absolutely.
And so it is it's a bonus if you're willing to do that. And quite frankly, there's no incentive to do it, and it's much scarier to do it. So I get it. So Justin, you have a lot of you're like the king of experience. We have worked with you to implement a lot of the value-based care, but you speak from this experience.
Yeah, no, absolutely. And a lot of that comes from, you mentioned product, right? And then we're talking insurance risk. We have so many different systems, right? And when I say systems, we're talking Medicare, commercial, Medicaid, that have different insurance amounts tied to the individuals, right? That you would be taking risk for. And my background was a fully integrated plan for Medicare and Medicaid, right? So you're able to take both sets of dollars together, right, and provide a more unified, bring those stakeholders together that you've talked about in a way that, when you're siloed, you just can't. So I guess where I go to is I found the value, particularly for community, home and community-based services. Can you tell us your thoughts about home and community-based services and what you've worked?
Yeah, more than pleased to. It's always one of these moments where that's a wide open door that I kind of run full speed through. And so I tend to also realize, as I've listened to these, encounters in my past, I like it when people give me an example, something that's live to work with. They can rattle it around in their head. So to your point, I was actually on site with one of our PACE centers not too long ago. And for those of you to the uninitiated, PACE is the program for all-inclusive care of the elderly. But to your point, it is a Medicare-driven program with a Medicaid component. So you have the federal and state elements. And to your point, it is a fully integrated delivery focused on that home and community-based approach, right? Mm-hmm. So it's kind of the perfect example to play with as we speak. And, if any part of my next statement comes out as my taking credit for my team's good work, let me apologize in advance, because these people are phenomenal. The staff are phenomenal. The members are phenomenal. The participants are phenomenal. And in this, they're engaged in their own care by the very virtue of how PACE is set up, it looks to reward living, right? It looks to reward experience. It looks to see people as that story that I spoke of initially. And yes, there are absolutely medical components, right? You know, multi-specialty care, primary care, any unexpected or unplanned episodes that might come through. But the real magic happens in their social engagement. It's in their travel. It's in their family story. It's in coming to the PACE Center. Mm-hmm. And it really is illustrative of, to me, that perfect Venn diagram of where great attention to social determinants, great attention to the medical components, and great attention to that psychosocial, spiritual, emotional component intersect. And that, to me, is value-based care, right? Value-based care, I know, carries a connotation of, you know, upside, downside risk, subdelegation, capitation, all those terms, and that's fine. That's
the financial. That, to me, is the economics of it. That's not the delivery of it.
It's not the heart of it, right? You know, you pay your check at a restaurant, but the restaurant is not about the check. The restaurant is about the experience, right? And so to that end, that's what we always say when we define value-based care. The setting is home and community-based. It's where patients and families want to be. It's where outcomes can be delivered. And it's where the highest level of engagement in someone's social and emotional well-being takes place. The model is a proven chronic illness model that, you know, as you might expect, is rooted in statistical outcomes and clinical outcomes. And the social side is based in the health equity, you know, components of this. And we as an organization, I won't turn this into a commercial, but have aggressively pursued health equity certifications because we believe in that three-legged stool, if you will, of how to approach true value-based care.
So these models have been around for decades. And this is what I like to bring up in a lot of the discussion, because we tend to think like, ooh, the latest new idea is the greatest. I am super passionate about PACE, fully integrated programs, but they've been around for a really long time. Why do you think they're getting more traction, particularly PACE, at this point in time?
You know, I don't ever point to one moment, right? You know, it's almost like asking somebody, how did society get the way it is? There's no one moment. There's certainly a precipitating set of factors, but let's lay out a couple of those. One, you know, the aging population, the supply-demand curve is clearly something that everybody is aware of, a diminishing workforce, a rapidly multiplying population in need of care, and that dynamic has shifted. You have the, the sandwich generation, where adults caring for children and their own parents, right? And so where often does that happen? In the home, as opposed to, you know, the other piece. And then there's even very simple but kind of mind-blowing numbers. We built a healthcare ecosystem around the few days a year that you're in a hospital, a physician's office, a nursing home, never really fully giving credit to the fact that you're probably in your own private residence 300, 320, 350, if it's a great year, 360 days, right? Sheer percentages, why is more of the healthcare ecosystem not driven where you're at 90, 95% of the time?
Absolutely.
Right? And if you really think about wellness over sickness or proactivity over reactivity, that's where that's going to happen. Lowest cost, ideal setting, most engaged patient population, and ultimately gives the clinical practitioners themselves that sense of fulfillment that many of us daydreamed about in trying to really make a difference.
So how do we get a PACE on every corner?
Well, Walgreens there's real estate available because Village MD has opened up.
Oh boy.
I think there's a new business model coming out. So, do you want to answer that? Because I have another question.
How do we get a PACE on every quarter?
Or do we just move on?
Do I get any free passes that I can take?
I know.
I think honestly, it's I hate the word grassroots because it has such an overplayed usage, but the reality is, it's to your point. It's been around a long time. You don't find anybody who's experienced it and not liked it. What you find more often than not is those who have said, I don't know what that is. Right. And so it's like anything in its organic state. You really just need to look for every opportunity to promote and discuss and press. And so thank you for that being here today. Secondly, it's as the members themselves are engaged, having them tell the story. And then, of course, there are legislative and political components to that, too. Anything that's codependent on budgets at a state and federal level has more headwinds than a lot of programs do as well. But, you know, whether it's PACE or whether it's accountable care or whether it's, any of the other programs that approach this, you're starting to spread the word.
So that was going to be my next point is, so a lot of people bash CMS, and there's a lot of stuff that they do that is, I think, a little bit too aggressive, and it aggregates sort of ambiguously, and it shouldn't. But CMMI, in my opinion, is one of the really good things that came from ACA. And there have been a lot of really good programs that have come out of that. And so the one that I want to talk about a little bit today is Guide. Mm-hmm. So it's one of the new, so just to put this into context for the people that are listening that may not know this, is CMMI is the innovation center under the Centers for Medicare and Medicaid, right? And they have, in the first decade of their existence, they put 50 programs into place, and they are all value-based programs. And their goal is that every Medicare and most Medicaid people will be under a form of value-based care by 2030. And that's only 6 years from now. So like that's a very aspirational, that's their second decade plan. So this new program guide, I think, is a perfect example of what you're talking about. And we talked to a number of clients that have implemented it or are going to implement it as part of their value-based care portfolio. But it's those that are listening, it's a new program this year. It's guiding an improved dementia experience. I have to look at that because it's a new acronym for me. Unlike the other ones, I can like spit out still at the top. But,
CMS never puts out new acronyms.
No. But this one actually, when you talk about the sandwich generation, this one's actually near and dear to my heart because my mom was recently diagnosed with moderately to severe vascular dementia, which again, for those that are listening, that is actually will be her cause of death from being an uncontrolled diabetic for 10 years. And so like when we talk about, cardiometabolic disease and we talk about all these things that are happening in your 30s, your 40s, you're setting yourself up for that dementia, right? She set herself on that path, but we are now finding ourselves as a family trying to navigate dementia, right? And so I was like, I've got to ask Andrew after this if he has anything over on the East Coast so tell us, you guys are one of the inaugural participants in the guide program beginning this year.
Yes, absolutely correct. There's about a dozen things in there I wanted to get to.
Yeah,
so
I figured I just
here.
asked you like a ton, but this is I love talking about these value-based programs.
So on, I think we got here by the route of you explaining where CMS and CMMI sort of motivations lie in that 2030 deadline. And it's funny you say that, in our office, I have a little countdown clock, right? And it's actually set to 2030. And I don't remember the last count. I think it's a little over 2,200 days, probably give or take. But that notion is that to us is a bit of the North Star, right? That is that moment and they've not shown any wavering from that commitment with emerging models and with recommitment to those models and making them move from, demonstration projects into statutory projects or programs. So we believe fully in the 2030 ambition, right? And Chapters and CareNu by its portfolio of business investments are all in on that. And so the guide model was one that we pursued with vigor for several reasons. One, it fits our core audience, our core disease management platform. It's certainly something that many of us have a personal connection with. I do have no problem giving a shameless plug. I had the privilege of serving on the Gulf Coast chapter of the Alzheimer's Association board. And those folks do tremendous work. And for those who have ever personally experienced it with a family member, professionally experienced it in a clinical caregiving setting, the stress it takes not just on the patient, but on the family as well. So when you start to look at CMMI investing in models that are equally focused on caring for a patient, but also the patient's social environment, that to me is a giant leap forward. Right? There's lots and lots of programs out there, all of which are exceptional, but they're very clinically driven, right? It's all about a certain test. It's all about a certain threshold. There's not as many models that are focused on that social component, the familial component, the societal component. And you start to see things like ACO REACH and the GUIDE program. And I want to give credit, to the federal team for realizing and bringing, it's a big ship. They always say, turning a giant ship takes time. So this to me is no small feat, right? They're starting to move into things that are disease specific, but take into account those three circles that I say create the ideal Venn diagram for successful value-based care. And this is just yet another illustration of it, right? And so, I have nothing, but we haven't seen it kick off yet. Certainly there are bumps or rough edges to any program, no matter who administers it. So we'll get through that. But yeah, we're certainly excited about that.
Yeah, it's good stuff.
Yeah, got to give them credit. 50 plus programs in the first 10 years.
Yeah.
Right?
Yeah.
I mean, I try it when come Friday night, we had to figure out where we're going to dinner as a family. There's four of us and we can't settle on one answer. I cannot imagine finding a perfect solution for all of America.
We can't even have family movie night anymore in my house. Like literally, I think we can have one a year.
That's when everyone has their phone out staring at something different on the couch together.
Yeah. Or like you get into it's either you pick something and within 5 minutes someone leaves, or you get in such an epic fight that you can't even pick a movie and then someone storms off and then you end up with like 2 or 3 people at best. And then I end up just going to bed. It's like, well, we tried. So anyways.
I'm going to work on healthcare. Some things I've given up on.
So,
getting a little more serious. Like, when I say serious, like
No, sorry, go ahead.
serious about your legacy. Can you tell us what you would like your legacy to be in healthcare?
That's a great question, and there's so many. I'm going to address it from kind of an organizational perspective, because certainly what I ambition to do is very different. And maybe I'll answer both just to give the listeners a wider view. So organizationally, if this all happened tomorrow, if I retired tomorrow and Chapters said that's it, we are just going to freeze everything we've ever done, and we want to be remembered for this day, I hope that people remember Chapters as an organization that was focused on three things. First and foremost, a superior experience by not just the patients, but their families, the volunteers, the donors, the philanthropic community, everything that we support. We wanted to have changed how our communities viewed the resource that we were. Because that does, ebb and flow, where some days we're doing lots of things for lots of people, other days we're more focused. But we want to always be able to say we made a big difference. We weren't a transactional part of someone's life. I would say the second piece that would, be a great legacy organization to leave is that little eye roll when someone's like, man, they were always on the edge. They were always pushing the envelope. They weren't afraid to try, bend, don't break, be innovators, right? I would be really sad if we were ever thought of in the same sentence as the word status quo, right? That'd be a fail to me.
That would be the opposite of legacy.
Exactly, right? I mean, that's certainly a legacy, but it's not one that we want to leave. And I'm not suggesting there's not a place for that. There's great parts of healthcare that don't need to evolve as much. That's just not where we're focusing our time. And I'll offer you this one because it's important for me. If I as a leader was fortunate enough to leave a legacy where people thought, he made the team his focus, and in doing so, any success he may have incurred was done the right way. We have, I think we're trademarked. If not, we're working on being trademarked, on a phrase that I believe very passionately about. And there's only two jobs, no matter what our HR team would say. The manual is bigger than this, but there's only real two jobs at our organization, and that's be caring for patients or caring for those who do. And if you can't look at the stack of work on your desk and correlate it to either improving one of our team members' experiences or one of our patients' experiences, rethink your priority set. Because I do strongly believe that is those are the lead measures that ultimately create the change that you're looking to implement. So as legacies go, personally, I want to have been that kind of leader, and organizationally, we want to have left that kind of mark.
Well, that sounds like a piece of cake, though.
Done and done. I mean, all you got to do is say it and will it into existence, right?
All right.
No, it might seem some of it. I mean, you talked about in-home patient care and all that, and that's what did you say? Say that one more time. Either be caring for a patient or
there are two jobs at our organization: be caring for patients or caring for those who do.
Caring for those who do.
I love that.
That's fantastic. Yes.
So, what are some of the key areas that have to be addressed to move towards value-based care? For those that are listening, they're like, if I have to do it by 2030, maybe I do have to start thinking about this. We talk about this all the time. I was on a call this morning talking about this with a health system that's fully integrated with the change management that they're dealing with to try to move more towards value and away from fee-for-service transactional.
That's right. And so, we've had this laugh. I have an executive on my team, and she's a shy individual, doesn't like to be called out by name, so I'll avoid that. But she's listening right now. She knows I'm talking about her. She asked me once, she said, so what are we going to do when we're successful? And I said, that's a great question, right? Because if you sell this to your board or to your investors or to your stakeholders or whomever it is you need to help convince come on this journey, there's going to be a moment where they look at you and say, that's a good idea. Let's do that. And then it's going to land back in your court. It's intellectual tennis. Now the ball's back to me, and what am I going to do with it? And so here's what I would suggest.
You're going to call BP too.
That's right. There you go.
Sorry.
It starts with this.
From our sponsor.
But wait, there's more. We can have some laughs about that, but that is not an inaccurate statement. There are answers out there. This is not something that's never been done. It's not something that can't be done. It just requires, like we talked about with an aquarium or with a 10-hour, 12-hour, 15-hour race, right? It's one step at a time. And you don't think about a finish line or finished product. You think about the next water station. You think about the next waypoint, right? And for those of you who've ever done a marathon
I'm literally envisioning putting ice in my cap as I'm trying to finish the last 3 miles of the run.
Yeah. A race medal's a long way off. I need a cup of Gatorade. I just got to get there next. And to that end, I would say that design or the migration to value-based care follows a pathway. Take a look at your organization and everything that you have built. check that, right? Is this ready? And if it's not, then you have to make sure and you're following kind of a rate limiting or a lowest common denominator approach. So is your workforce ready for value-based care? Are their compensation structures aligned to quality over quantity? Are there recruitment, training, development, retention tools? Are there promotionary pathways for those who perform well? Because it's not about necessarily tenure. There are some skill sets that translates better. You can follow the workforce path. That becomes very real. What are your capital needs, right? If you're going to have reserves to take a dual integrated plan, to be in an ACO, right? Do you need to drive margins for a few years in order to put reserves on the shelf and make that migration? Do you have an outside investor? Do you have to change your real estate portfolio to be less intensive on acute care structure and more on home community base? So there's that component, right? And then you have to look at your business acumen. Who is handling your contracts? How locked into certain things are you? What is your ability to handle a massive switch from revenue streams based on, all these components are things, there's not one solution. You don't wake up one day and hire a value-based care expert and say, now go do your thing in a vacuum. Value-based care is not a niche. It's not a single provider or a single service line. It has to be kind of an organizational ethos. And that's what I would suggest to people is value-based care often carries this sort of business acumen connotation. What I would suggest is your company or is your organization ready to move to a quality over quantity approach? Because that's a little bit different. You can embrace quality over quantity and still keep a lot of your traditional business models, but it will change the whole ethos, which is a nice transition to when you have to put your money at risk, right? Mm-hmm. If you're just really focused on quality, you can still be in a fee-for-service environment delivering exceptional, innovative care and starting to squirrel away a few dollars for when you have to put some things at risk in the more traditional definition of the word. So I'm all over the place, but
well, no, I think,
exactly.
and I appreciated what you said too about you can't just hire a value-based care expert because it's true. It is change management, and you have to operationalize some things. You have to. And like we have a lot of times where we literally get the call because McKinsey's come in or some big firm has come in and dropped it, and everyone's gone, yes, we're going to do value-based care. And then they leave and everyone's like, what do we do now?
Yeah.
I mean, now we have to do all the things that you just said. And we don't even know what all those things are. And then that's when we get the calls like, well, can you actually help us do it? Because, it's like, it is redesign. It is structural redesign. It is it is really system redesign. It's engineering almost, right? It's like, how do I re-engineer?
Gone full circle, back to the system.
My wife and I, we like to pick at each other because she's, also in the healthcare space. And so our dinner talk is quite interesting, but she got chickens not too long ago. And I kind of chuckled. I said, so are we a farmer now?
Wait, chickens like?
Yeah, actual chickens, egg-laying chickens. They're in a coop and the whole thing. Yeah. And if you ever came to know me as an individual, that this is about as far from my natural tendency as possible. And I said, are we farmers? And she said, oh, yeah, because when you have a chicken, you're automatically a farmer. But I kind of laugh because the analogy here is apropos. So are we in value-based care now because we hired this one person?
Yeah, exactly.
No, one chicken does not a farmer make any more than one employee does a value-based design make, right? It's a commitment. If you want to be a farmer and a good one, you need the space, you need the acumen, you need someone to teach you, you need all the equipment, you need to understand the weather patterns. To be in value-based care is not just a trend or a current payment model or a single contract.
And that's why that's why I think organizations that check the box and dip their toe in, it doesn't work very well because it's a thing. So Justin, you're trying to jump in. Sorry.
Well, now I know how he's getting in such good shape as he's chasing the chickens around.
Well, I was gonna,
they hide their eggs.
So when do you become a farmer? Do you have to have pigs too, or what's the? Where's
you're
the
getting
line?
ready for the last question.
Yeah. So yeah.
Wait. Yes. Do you have a definition of when you become a farmer?
I think we were done when my legacy is left because I don't have farming in my future anytime soon. All right.
But we have a last question for you.
We do.
Please.
So we ask all our guests what their buy a world of Coke or when pigs fly
When
idea.
pigs fly. That's where I was going.
Yes. Right.
Segue.
For fixing the healthcare system. So what is yours?
I kind of gave away my secret a little earlier, and I don't know if this is the technical definition of how the phrase Occam's razor is used, but what I'd like to impart is I do actually believe that the solutions oftentimes are as simple as they're presented, right? healthcare at its core, yes, there are, components. Yes, there are, tests and diagnoses codes. Those are all very vital parts of it. But what it really is humans caring for humans for the most part. Now, when AI, takes over and we're all working for the machines, we'll revise this podcast then. But until that day,
the machines will revise it for us.
They'll do it for us, right? Yeah, we won't even need it for that. But until then, I think we have some time. It is humans caring for humans, right? It is not humans administering tests to humans. Caring is, I think, the critical word. So when we as the organization, believe you have two jobs, tie the work on your desk to one of two jobs, taking care of our patients. And if you're not in that capacity, then you're taking care of those who do. That, to me, I believe, would fundamentally shift healthcare. There's a lot of headwinds to getting there. There's investors who need their money back. There's regulatory statutes that keep things from getting done. There's a lot of red tape involved. It's what we've built. We can unwind it just the way we wound it. But I do think it starts with fundamentally recognizing that healthcare, when done right, whether it's acute, post-acute, non-acute, whatever it might be, it is fundamentally humans caring for humans. And if we can strip all the noise and all the layers of nonsense away from that principle and direct our resources, our time, and our attention to that, I think things change.
Wow. Mic drop.
That's it.
And that would be my Coke, because my wife would disown me if that was my Pepsi. We're a Coca-Cola household unwaveringly.
Well,
Boom, roasted.
Sometimes, is that the cue for the song?
No.
Yeah.
Okay.
Oh, come on. We aren't going to sing it today?
Yeah, we're going to get a cease and
All right.
desist.
No, I never
do
said
it real quick. Do it real quick.
I'd like to teach the...
Never
Never mind.
off.
Forget it.
All right. It's not going to happen today.
It's only a matter
We
of
should
time
have
before
stopped at
Coke
Nikki
sues us.
Sixx, right? So we kickstart my heart if we want to do that one. No.
They would.
That I was not. I'll be a farmer before I'll be a Vince Neil replacement. That's for
I'm
sure.
like, thank God you didn't keep singing, because I wasn't ready for that. Well, Andrew, thank you so much
Yes,
for your
thank you
time
for being
today.
here.
We appreciate you coming.
My pleasure. Thanks for highlighting something so important to us.
Well, thanks again. I'm Ellen Brown.
I'm Dave Pavlik.
I'm Justin Politti.
We are the partners at BP2 Health, your best chance for real change. As you can tell, we talk about this stuff all day. Find us on our website at bp2health.com.